name is Vikas Arya, Healthcare Advisory Manager at Optimity Advisors, and I will be your moderator today. We understand how challenging it can be to achieve sustained success as an ACO. That is why I am excited to present today's webinar, 4 key priorities for ACO success: people, process, technology, and financials. Founded in 2009, Optimity Advisors is a strategy, operations, and information technology advisory firm that helps clients in complex industries to navigate rapid market and technological change. Our healthcare practice has helped several ACOs, including Catholic Medical Partners, become successful by focusing on these 4 key priorities. And with that, I'd like to introduce today's speakers: Dennis R. Horrigan, President and CEO of Catholic Medical Partners, and Doris Stein, Healthcare Partner at Optimity Advisors. Dennis and his management team at Catholic Medical Partners are managing over $1 billion in healthcare expenditures using a population health business model. CMP was one of the top performing shared saving accountable care organizations in the country. Doris leads the government programs practice for Optimity Advisors and is a frequent industry speaker about ACOs. Most recently, she presented at the European Health Conference and the ACO Southeast Regional Conference. She was the lead advisor in conducting the ACO assessment for CMP. Before we hear from our experts, I would like to mention that we welcome your questions throughout the webinar. To submit your questions, please type them into the question window on the GoToWebinar control panel and press submit. We'll get to as many questions as we can during the Q&A session after we hear from Dennis and Doris. We are recording today's webinar and will post it as well as the presentation slides on the Optimity Advisors website. You will receive an email once they are available in the event you would like to watch it again or share with your colleagues. Without further ado, I would like to welcome Doris Stein.
Thank you, Vikas, and thank you everybody for attending our webinar today. Very excited to be talking with you about ACOs. Talk a little bit about our agenda. The first thing we're going to talk to you about is the different ACO network options that are out there in the ACO models. We're going to talk to you a little bit about the maturity model, what the integrated care system looks like, and then we're going to give you some examples of what we've seen in the industry as we've been working with the ACOs around people, process, technology, and financials. And then what I'm going to do is hand it over to Dennis, and Dennis is going to be talking about managing risk and margin, and then talk about some of the experiences that he's had at Catholic Medical Partners. And then at the end, we'll save time for questions. Okay? So let's go to the next slide, which is the ACO network options. So this really encompasses the eight or so options that are out there for ACOs, and depending on some of you are existing ACOs, some of you are wanting to become an ACO, and it's really a different dynamic and different interests and expectations depending on what option you either have or that you want to become. And it's going to depend on what you have. For example, if you are a physician group only, your main focus is going to be shared savings. If you're a hospital, it's going to be about protecting your population. If you are an academic medical center, it's really going to be looking at protecting your volume and looking at the teaching aspect of this as well. If you're a health plan physician model, it's going to be you're going to be wanting to obviously attract market share. So each of these, as you want to become an ACO or you already are in an ACO, these are different things that you have to look at, and many others. Those were just examples that I gave as you look at your network options. So the ACO maturity model. So some of you that we've seen that are on this webinar are in different stages of the ACO maturity model. But what we've done in our experiences is put this into 3 categories that you see here. The assessment and planning stage. And this is the first step, and this takes anywhere, and these are just general approximations, anywhere from 0 to 9 months. And what's important here, and really what I've seen or what Optimity's seen as we've worked with these ACOs, is development of that business plan. It's really important to look at what are your short-term priorities, what are your long-term priorities, what's your resource mix going to be as you start an ACO, what's your gain-sharing model going to be. So all of these things you need to look at. And another important piece is your leadership governance structure. What's going to be that steering committee look like? How is it going to be, the leadership going to be identified and structured as you build or as you're in your ACO? The next stages are the implement and sustain. And this is truly as you are implementing and live as an ACO and you're sustaining as an ACO. So you really need to look at what is your culture like? How is it driving your operations? What are your shared financial gains and losses? Are you really collecting and integrating the right data? I mean, that is so important. What we've seen in some of these organizations is they have disparate systems. They can't really gather that data and standardize it to be able to report on it. And obviously, as you're looking at your shared savings models and really looking at your patient benchmarks, data is so critical. So it's really important to really understand and how you're integrating the right data and ability to report on those quality measures. And then as you're in implementation mode, or you're past that and you're growing and you're evaluating, you really got to look at, you know, real-time feedback. What are your members saying? Are you able to measure actuals versus benchmarks? And really continually assessing your risk across the ACO, and then getting performance feedback from not only your members, your community organizations, your providers, et cetera. So this is kind of what we see as examples in that ACO life cycle. So this is, you're going to hear me talk about, and I love as I go into this, I really like to simplify this and to put these into these 4 pillars with the member in the center of all of this. So really, what is your people, process, financials, and technologies? And as we've done these assessments for organizations, we've gone in and looked in these areas and identified what are the gaps and what are the recommendations and roadmap that you need to look at in each of these different areas. So what I'm going to do now is just to start to give some examples of what we've seen in the organizations and industries about how you need to contribute to ACO success. So let's start with the people side of this. So the people component is so important. And as I mentioned before, one of the examples that we've seen for successful ACOs is really effectively setting up that governance structure. What is your steering committee made up? Are all the provider groups in the ACO represented in that governance structure, or that executive committee if you started that? Because really you need to get the input, the leadership, the buy-in, the support from everyone in your organization. So that's really, really important. Physician engagement. You really need to look at a single, consistent physician and contracting strategy. You need to make sure that your providers understand what their incentives are, that it's transparent to them, that you're giving them, as I mentioned before, the data that they need to understand if they're meeting their incentives. So really you need to make sure that you've got that contracting and strategy in place. And then really engaging those physicians. What are they looking at to change practice patterns? Are they practicing in the teams? What are their referral patterns look like? You know, when I've gone into organizations and we've interviewed the physicians, first thing they ask is, what's in it for me? How am I going to be impacted? How can I contribute? So you really need to making sure that you're engaging physicians and looking at, you know, what their practice patterns are and what they're doing, and have they implemented EHRs, et cetera. And then really the culture is so important as well, is making sure your culture supports the physician and the leadership, the physicians and the leadership. And then catastrophic patient management. What are your cost containment strategies? What are you doing to look at some of your population that has the most significant expenses? You know, what's the ER readmissions? What's the ER utilization, et cetera? So these are some of the things. And I also want to add with the people, you really need to understand in your business plan what kind of organization you're going to set up to support this. Are you going to have IT support, because IT is such a critical? Are you going to have a finance person? I've looked at organizations where they've had teams of IT people that go out to the providers to help them with maintenance and setting up their IT infrastructure and making sure that their EHRs are implemented correctly. So these are some of the areas around people. Process. Okay, process is a very interesting one as well. Health and wellness. Obviously, we want to make sure with an ACO or not an ACO, making sure that patients are really taking an active role in their care. What decision making are they doing? How are they being communicated to? Because we need to monitor this population to make sure that we're understanding them, understanding their needs. How are they impacted by the community? How are they networked with the community? What are your outreach programs that you're doing with these with your population as well? I've seen robust outreach programs. I've seen very limited, but really that's going to be a key factor is how do you outreach to these members to make sure that they're getting the care that they need. Focus goals. Need to make sure that physicians, an example of one ACO, what they did was they directed the physicians as a short-term goal, having them focus on their highest risk patients and looking at those high or weightiest quality measures. So really, what are the goals that you're also looking at for readmission reduction, ER utilization? What are you looking at there, and what are those goals? And again, making sure they're transparent to your providers. Care delivery model, that's so important. It needs to be integrated with all the things that we've talked about, your health and wellness, your case management, your utilization management, your disease management. That all has to be integrated together. And then again, network management, the referral patterns have to be monitored. You want to make sure that you're going in the network and making sure that they're not referring to outside or whatever where possible. Another best practice that we've seen is, and some of you may have been doing this that are already in ACOs, is care managers and care coordinators. I've seen organizations that have put these care managers into the primary care offices, into the ERs, into the hospitals to make sure that they can coordinate the care for their members. Okay, from a technology perspective, I think this is very, very critical, as I mentioned before. The EHRs are so important to making sure that you can standardize and collect the data. I've seen organizations that they say, I come in, they say, yeah, everyone has an EHR, but then when you go in there, they have 10 different EHR systems. They don't connect to each other, and the data that they have in each of their systems is very different. A best practice that I've seen also is one of our clients is Kaiser Permanente. Everybody's heard of Kaiser Permanente. It's amazing. You go into any of their offices, they're paperless. There's no folders, nothing. Everything is paperless. It's all in their EHR system. And then, in addition, what they've done is they have their EHR system is set up so that if I'm a member or I'm a patient and I go in and see my ophthalmologist can go right in the EHR system and say, oh my goodness, this person needs a vaccination or this person needs a mammogram. And being able to connect that care and really understand what that member needs from end to end is really critical, and the EHR really helps you do that. And the other thing that Kaiser does is their electronic medical system is real-time. It does electronic ordering. It does digital imaging. And they use population tools and the member website to really connect to that EHR system. And so that, as you become an ACO or you are an ACO, is really looking at how to enhance that or to develop that so that everything is really fully integrated. Reporting. Reporting is so important as well. I've seen organizations where they can't, for the MSSP program, where they had the data but they weren't even able to standardize it or collect it appropriately to be able to report on their data. And again, it's so important to get that reporting out to all your providers and to have it standardized so that everybody is really looking at the same thing and is measured across the same metrics as well. And then really looking at your data strategy. And it really has to be owned by everybody. What is your data strategy? Are you going to have IT resources to support the strategy? How is that all going to work? And then the other thing is not only your data strategy, but just tracking. How are you going to track compliance? How are you going to track performance? How are you going to, and how to be able to do it by different areas? Can you do it by patient? Can you do it by provider? Can you do it by practice? How can you track your data, and can you be able to do it by the different modes? Okay, I only have a couple minutes left, right? I'm getting the time mark already. Dennis and I can talk about this all day. So the financial pillar is also very important. So really, what is your financial model going to look like? How how does your market and population impact utilization? What are your pay performance model? And I know that as Dennis and I talk, actuary is so important. What is your gain sharing model and your revenue model going to look like? Is it going to be based by provider, by specialty, by region? Because each region, if you're in multiple regions, that's going to be different. So how is that going to work? By population? And then looking at your total medical expenditures. What are goals or things that you can do to lower costs? Maybe instead of looking at ambulatory clinics versus hospital, looking at how can we decrease our ER and hospital utilization? So these are huge money savers, and you really need to look at your total medical expenditures to be able to understand and to be able to incentivize. And then the physician incentive model as well needs to be looked at. So again, quick highlight. I spoke very quickly. I'm a fast talker, but there's just so much more in these specific areas that these are just some examples of things that we've seen that have made ACO successful. So now I'm going to hand it over to Dennis, who's going to talk to you about CMP.
Thanks, Doris. Many CEOs, chief financial officers, and medical leaders, when they think about the ACO, they kind of wonder, what is the business model? How do you actually create a margin from managing a population? And it's a very interesting question because it forces you to look at the population in terms of utilization that is value-based and utilization that isn't value-based. And there's a couple of concepts that are important. One is understanding avoidable admissions, because if you look at your hospital data, you'll probably see that 30 to 40% of your medical admissions are considered avoidable. And once you look at that and you're running a hospital, you say, well, how am I going to replace that revenue? It becomes a major barrier to even thinking about this. I think the 30-day readmission being a value-based metric is being pretty well understood. So what one has to do is then understand, if you're managing a population, you have to determine, is your system, your network, managing what portion of the population? And for those of you that are involved in risk contracting, you'll know that in-network utilization becomes an important consideration, because as you're taking unnecessary utilization out, you want to really replace that with favorable utilization. This, every year we sit down with our health system partner and we really look at expected volume. We look at volume that we would consider to be unnecessary. And what we have to do is make predictions about a financial plan, and then we implement. So I think the first part of understanding an ACO is, do you have an understanding of the business model? Because it not only affects your health system, if you're going to manage and reduce the emergency room utilization, it will affect your ER doctors. If you're going to impact CAT scans, it will impact your radiologist. And you have to be able to find a way to explain how shared savings brings dollars back in. So I guess ACO 101 is, what is the business model for population management? And you probably need an epidemiologist and some public health people around to help you look in the mirror and see, what kind of utilization you can better manage. The people kind of ask us a lot, well, how did Catholic Medical Partners, get started, and what was our path? And we created this simple diagram. We started, over 10 years ago. And the first thing we did is, I often say this, I had a group of doctors and I said to them, how well do you manage hypertension? And of course everybody said, pretty well. And I said, well, tell me what percentage of your patients are in control? And everybody kind of looked at me and they didn't know. So we put together some simple registries. We took patients in a practice, we put them out on our website, we put a best practice guideline, and we said to the doctors, please tell us both process and outcome measures for diabetes, congestive heart failure, COPD, and some others. And while initially there was a lot of resistance to this because it was self-reported quality and people thought they were doing just fine, they realized that there was room for improvement. So the next thing that we did is, because at that time most of the doctors were on paper, we decided we were going to support EHR adoption and reporting. So we invested millions of dollars in supporting the doctors in adopting the electronic health record. We got support from the health plans. And then what we did, and Doris mentioned this, is we actually have a technology team that goes around to the offices, and we can actually convert a paper practice into a full electronic record system. But we actually teach data governance and how to enter data so it can be reported. We teach interoperability using both the direct and the connect methods and meaningful use. So that was about the first 3 or 4 years. And then when the epiphany was taking place, the doctors in the office said, look, now we understand we can't get all this work done. So then we invested in embedded care coordination. And I always say that to my health plan colleagues that care management should be in the doctor's office, not in the health plan. So we have over 150 care coordinators in offices, both primary care and internal medicine subspecialty. And it warms my heart when they talk about their encounters with patients. And one doctor said to me, you know, I was really reluctant to bring a care coordinator in, and she's doing what I'm doing. And we said, that's it. That's what we want, is you need more capacity. Then we moved quickly to the patient-centered medical home. Actually, everything we were doing aligned with the patient-centered medical home. So we have about 90% of our patients are being treated within a PCMH level 3. More recently, we tested ourselves against NCQA accreditation for an ACO. And as you know, it's a pretty structure, process, and outcome-driven set of standards, and we received accreditation for our Medicare at a level 3 and for our commercial level 2. The reason we got level 2 on commercial is we're not part of a national reporting, which, you know, we understood. We weren't happy with it, but NCQA accreditation standards will help you in terms of understanding the accreditation process, and everything that Doris has said about people, process, technology, and finance all comes together. And then we use the high-performing healthcare system model and framework from the Commonwealth Foundation. If you care to look at that, it kind of sets a set of principles and provisions to guide you along the way. The next slide, most of you have probably seen, but I just want to direct you to the arrow that says total cost of care accountability. And I want to refresh your memory. There's 3 people that actually are the originators of this term. One is Sidney Garfield, who you probably remember started Kaiser. Then there's Paul Elwood from the Jackson Hole group that really was the founding person with the HMO movement, and more recently Elliot Fisher, who is putting forth these concepts of both clinical and financial integration. So you are not only responsible clinically, but you are financially. So this is another subject that scares people when you're figuring out how quickly can you move from a fee-for-service to full risk and accountability. And we use kind of a dimmer switch. So we turn the lights off and we kind of turn on slowly the dimmer switch until the lights begin to come on. And we judge, you know, how quickly we can go. And that really means that you have to have a financial sense of how to stay stable, and you have to have reliable processes, reporting to be able to create the care management systems that are going to be needed both in the doctor's office and within the other healthcare sites. Go to the next. So when we come to work in the morning, I always say to myself, well, how are we helping the doctors in the office, because they're going to see 20 or 30 people every day, and we have hundreds of doctors, so that's thousands of visits. So what we try to do is we've built systems to help the practices understand how to prevent inpatient admissions, how to identify high-risk patients, how to follow up for people who are not in control, how to use information to determine what's appropriate and inappropriate, and making the right referrals. We do provide clinical outcomes on a semi-annual basis. We let the doctors know about their readmissions, their avoidable admissions, and in-network services. And expense management becomes, very key for any health system that's involved in this, particularly if you're going to see an overall reduction in your admission rate. This particular slide in the last one comes compliments of the advisory board. They put these together, and they gave us permission to use them. The next slide gets right to the finances. And what you'll see here is the basic per capita expenditures for all ACOs. And in the blue on the far left, you'll see that the average cost per beneficiary was about $10,470. And after the first performance year, that reduction moved to $10,388, which is a very small reduction. We then looked at the ACOs that had shared savings, and you can read these. You'll see there was a 6% reduction, and 58 out of the 220, or a little bit more than 25%, achieved shared savings. And this should be no surprise to anyone that understands innovation, because usually what they say, about a third of the people do well, a third kind of average out, and a third don't do well. We actually reduced our historical benchmark by 13%, which was beyond our expectation. But what is more important for us is the current comparison between our benchmark and the rest of the country. We started being a low-cost area, and what we're faced with now is how much more reduction in the trend can we achieve. And early results for our second contract year show that our trend moved up by about 1.5 points. We don't know what our benchmark is, but this all leads our management team and board to say, well, maybe the benchmark should be a combination of the local and national costs. But that's a policy issue for another time. Let's go to the next slide. So, you're probably asking, well, how does this all happen? These are comparisons, again, between Catholic Medical Partners in the blue and other ACOs that were had shared savings. So we reduced inpatient expenditures by almost 18%. You see DME expenditures, skilled nursing. So you can see exactly in this business model what I was talking about. This has clear downward pressure on a health system's revenue. So you have to figure out how quickly you want to put the dimmer switch on, and how much more in-network services you can drive. We'll go to the next slide. Here's some other key metrics here. ER visits leading to hospitalizations, 28% reduction. Most of you know that most health systems and ACOs are working with observation units, and I think we did implement observation, and this really assisted us a great deal. We also have our own home home care company and health home, which also helps. You see the hospitalization rate reduction and our 30-day readmission. We do have a care transitions program where when someone's discharged, if the patient agrees, we send a nurse to the house, within 48 hours, and then we have a 7-day follow-up. While that sounds really very positive, we were surprised that 50% of the patients being discharged from the hospital didn't want a nurse visiting them within 48 hours, which really surprised us. But if I probably would have asked my father, God rest his soul, if he wanted, he probably would have said, "Are you kidding me? I don't need someone visiting me." So be aware that some of the things you'll try, you have to get kind of the consumer voice on how it's all working. Just a few more here. When you look at the quality metrics, if you make $1, you have to share that with the CMS, and then you get a quality metric. On the quality measures, there's 33 measures in 4 categories: the patient experience, care coordination, safety, prevention, and at-risk population. So on the far left, you'll see a measure for patient safety, falls screening. This has to come out of the EMR, and we did not do well. We were under the 30th percentile here, and this is the issue of documentation. If it's not documented, it isn't there. And then on the far right is the diabetes composite measure, which is A1C, LDL, and blood pressure control, in addition to smoking counseling. And what's very interesting here is only we were 31% met all of those measures. And when you think of diabetic care, and around the country, the best I've seen is probably 40% out of Minnesota. So lots of opportunity there in terms of just focusing your attention on a population at risk with grave consequences if not properly cared for. Next and last slide is, these are really related to the business model and to basically the care coordination quality measure. So as you know, ambulatory sensitive conditions are conditions that, if properly managed in the office, would not result in an admission, which really puts it in the care coordination and safety component of quality measurement. And the lower your number here is, the better. This is per 1,000 members. So you'll see our COPD and asthma, and then heart failure, which remains a challenge. Actually, our heart failure rates went up a little bit this past year, so our clinical integration committee is tackling that. And then you see our all-condition readmission that's risk standardized. So what I showed you is the business model, the key processes you have to have in place, the utilization and quality metrics, and this all really ties back to what Doris has said, is you have to build an operational system that is predictable and you can count on. If you simply go in and say we're going to save X% without knowing how you're going to do it or what impact, you're foolish. And you need to really bring together your interdisciplinary team and take a close look at this, because if you're going to manage risk, the ultimate issue here is if you're going to be at full risk, you need reserves. And what you don't want to do is get into a risk contract where you can't pay back if you have a loss. And for the hospitals, it's days cash on hand. And for a physician organization, it would be reserves that you put aside. So keep that in mind, and you really want to bring your actuaries and your medical staff together to take a good, clear look at this. But this is all doable. It's going to happen. It's just going to be a matter of whether we're going to direct it or it's going to be directed, from outside forces, through more punitive and pay-for-performance methods. So I'll stop there and we'll take some questions.
Great. Thank you, Dennis. Thank you, Doris, for a wonderful presentation. So we've received a lot of great questions, which I'm going to share with both of you in just a few minutes and with our attendees. But before we begin answering questions, I'd like to remind all of our attendees today that you still have time to submit your question. Just type your questions into the questions box on your GoToWebinar panel, and we will certainly try to get to them. So the first question we have this afternoon is for Doris, but certainly, Dennis, you feel free to weigh in. Doris, the first question is, in your experience, what are the top 2 challenges that ACOs face?
Okay, I would say in my experience, I think the top 2, one is EHR integration and workflow. You heard me talk about it several times when I was presenting. I've seen ACOs struggle with getting that workflow down, looking at their processes, getting that standardized data, and being able to report on it. And the second issue or challenge that I've seen, a major one, is really that upfront planning and prioritization. And as Dennis just talked about, if you're going to make a goal of reducing, by 20%, you really need to have a plan. What are your short-term and long-term goals to reducing expenditures, for example, by 20%? So I think really putting that business plan together and really putting that roadmap together and prioritizing to making sure that you have that business plan in place. Dennis, do you have any, what do you think of the 2?
Well, I think in a distributed network of doctors, so in our case, we have lots of independent doctors. So we use what we call a virtual organization. That is, we engage the doctors on a business model, a way to communicate, and support to their practice to get the work done. And this is the biggest challenge is, how do you work with a distributed network of providers in contrast to a system where all of the people work for you. And, we've had some success with this. It is a continuing issue of the demands in the environment to adapt to everything, reporting, quality, et cetera, aren't getting easier. So the challenge really is to work with the doctors in an effective way to improve their workflow. And if you can do that, you're going to have a greater potential for success.
Great. Thank you both. And Dennis, that's a great segue into our next question, which is, how did you get your providers to buy into your ACO strategy?
Yeah, we have great leadership on our board, and we have for the past 10 years. Many of the leaders, had previously worked for a staff model HMO, and they understood the model. The other thing is, during the 8 to 10 years ago, health plan profits were extraordinary across the country, and Buffalo is no different. So what became very clear is, if a health plan budgets 88 cents on the dollar for health care and it only costs them 85 cents, then there's a margin there that exceeds their budget. So it was very clear to the doctors that because they're managing patients, not benefits, that should be part of something that the doctor should benefit from. So how do you actually collaborate to achieve some of the savings that are being achieved? And this also was taking place at the same time that physician compensation was flattening out and in some cases declining. So I think conceptually our doctors were there. And the next question really that led to our success is we were able to establish effective contracts to support clinical integration.
Great. Thank you, Dennis. One more for Doris. What specifically does Optimity do to support organizations in becoming ACOs?
So what we've done is we've done different things for organizations, but the first step that we've done with ACOs is really to do what I call a rapid assessment. This is a 4 to 6 week engagement, and what we do is we go out to the organization, work with everyone and really understand what are their gaps, what are their issues, and really, again, looking at those 4 pillars: people, process, financial, technology, identify what those gaps are, and then come up with recommendations to resolve each of those gaps and put together a prioritization roadmap. As I talked about before, what's your roadmap? What's your short-term goals? What's your long-term goals, et cetera? So we've done that, and then some ACOs have hired us to continue to do the implementation for them as well, whether it be setting up the organization, the steering committee, being a program management office to help coordinate the implementation.
Excellent. Great. Thank you. Dennis, I believe this one here is for you. I'm going to read it out. Were there space issues when you moved care coordinators into provider offices?
Oh, great question. Not only space, but computers and other impact. We have some offices that have 3 or 4 nurses because the practices have 15 or 20,000 patients. So clearly, it is an issue. In most cases, the biggest challenge would be in a single physician office. And a lot of the solo doctors may have 2 or 3 exam rooms and a reception area, so it did create some problems. But those were more of the exception, and they were able to be solved.
Okay, great. Thank you, Dennis. The next question here is for both Doris and Dennis. It's really one of our attendees here wants to ask if their organization can hire CMP and Optimity to assist them with just the catastrophic cases. Account for about 70% of their ACO costs.
Okay, we'd need to definitely. I think we have who asked that question, right, Vikas? Right. So what we'll do, whoever asked that question, we can follow up with you and talk about. And absolutely, we can support in different ways. So we will follow up with that individual to talk about how Optimity and CMP can assist you. So we can take that offline and we'll get back to that person.
Wonderful.
The 2 issues there are predicting the catastrophic cases and also your reinsurance levels, depending on the size of the population. The prediction, I think, has an R-squared of about 0.45, or so half of the time you can predict, the other time it's tricky. So yeah, I think you need to do both. You need reinsurance, but I'm sure that Doris and her team would be able to, their data people would be able to help you and the finance team.
Mm-hmm.
Great. Thank you both. We do have a couple of questions from our attendees around being able to access copies of the presentation and the webinar. So I do want to repeat that the slides as well as the recording for this webinar will be available on the Optimity Advisors website after today's presentation. That is it for the questions. Let me just make sure I haven't missed anything before we sign off. So we have run out of time this afternoon. We're at 1:45. Thank you all for your questions. Thank you for your attendance this afternoon. And for all of you who attended today, we'll be certain to follow up with you directly. And if we weren't able to get to your questions, you can certainly email them directly to us. Thanks again for joining us, and we hope you'll be back soon for another one of our webinars. Have a great day.